Good afternoon, everyone. My topic is an OCT-based study of retinal nerve fiber layer changes in migraine. No financial interest involved. Migraine refers to a primary headache disorder commonly characterized by severe unilateral throbbing pain and may be associated with nausea, photophobia, phonophobia, and or preceding aura. The prevalence of the disease is somewhere between 2.6% and 21.7%. Women are affected more than men by almost 35%. Migraine is a transient phenomenon of cerebral vasoconstriction. The long-standing cases of migraine may lead to retinal structural abnormalities. The chronic migraine causes anomalies in microcirculation of optic nerve head and may cause retinal hypoperfusion. The retinal hyperperfusion finally leads to ganglion cell death in such patients. Aim of our study was to compare RNFL thickness between migraine patients and healthy controls and to assess the quadrant which is most affected by migraine. It was an observational case control study conducted in which we took 96 migraine cases and 96 healthy controls. Inclusion criteria included both male and female patients in the age group of 20 to 60 years who were diagnosed as migraine. Patients with glaucoma, high myopia, diabetic retinopathy, hypertensive retinopathy, retinal vascular occlusive disorders, and any other neuro-ophthalmic disorders were excluded from the study. Every cases and controls underwent local ocular examination that included best corrected visual acuity, color vision, Goldman measured IOP, slit lamp examination, fundus examination. Finally, OCT of the optic nerve head was performed to evaluate the average RNFL thickness and symmetry of both the eyes, in addition to the RNFL superior nasal, temporal, and inferior quadrant thickness. Results. In our study, the mean age group of the cases was 39 years plus minus 10.3 standard deviation, and that of the control group was 41 years plus minus 9.2 standard deviation. Out of the 96 migraine patients selected for study, 65 were female and 31 were males. RNFL thickness amongst cases and controls, the thinning was significantly more in cases. Out of 96 cases, 62 had RNFL thinning, the average value being 87 plus minus 9.2 micrometer. On comparing with controls, there was statistical significant difference with p-value less than 0.05. Maximum cases which had RMFL thinning were women. Out of the 62 patients which had RMFL thinning, 44 were women and 18 were men. On comparing with controls, there was no statistical difference. Maximum cases which had RMFL thinning belonged to the age group of 30 to 40 years. The mean age of the study sample was 39 plus minus 10.3 years. On comparing with controls, there was no statistical significant difference. Maximum number of cases had temporal quadrant thinning, value being 53 plus minus 10.1 micrometer. This was followed by nasal quadrant thinning, the value being 74 plus minus 11.6 micrometer. On comparing with controls, there was significant difference only in the temporal quadrant thickness with p-value less than 0.05. This is the data collected, and we can see only the average RNFL thickness and the temporal quadrant thickness showing significant values. The mean age of migraine patients in our study was 39 plus minus 10.3 years. This was fairly consistent with the study of Leslie-Kellman, in which the mean age of migraine was 37.7 plus minus 11.7. In our study, the average RNFL thickness was 87.8 plus minus 9.2, which was significantly thinner when compared to healthy controls. The result of our study corresponded with the results of Elizabeth Khosravi, which showed that RNFL thickness was significantly thinner in migraine patients when compared to the control group. In our study, the mean temporal quadrant thickness was 63 plus minus 10.1, which was found to be thinner when compared to controls. In the study of Martinez et al. Using OCT, he found that the RNFL was significantly thinner in the temporal region in migraine patients when compared with age-matched healthy subjects. Abnormal RNFL thickness has been observed in patients of Alzheimer's disease. So, RNFL thickness can be considered as a potential biomarker for Alzheimer's. RNFL thinning is associated with singulated cortex atrophy and episodic memory decline in old age. So, it can be used as a complementary index of neurocognitive degeneration. The thinning of RNFL is also associated with patients of multiple sclerosis. As we all know that multiple sclerosis is a central nervous system disease with optic neuritis being a manifestation. So, it can be considered as a biomarker of neuroaxonal damage in such patients. The limitation of this study was that we did not assess the ONH parameters and RNFL thickness based on the severity of the disease using the MIDAS score. The migraine disability assessment score is a well-known tool to assess the severity of migraine. Conclusion. Migraine is a common problem. It is the second most common cause of headache affecting women primarily. There seems to be a strong correlation between average RNFL thickness and migraine, with RNFL in temporal quadrant being significantly thinner in migraine patients. OCT has recognized a new pathway for anticipating neurological disorders such as Alzheimer's and multiple sclerosis. Though this remains a question that whether OCT can be used as a screening tool for diagnosis neurological disorders. Several studies need to be performed. A much more defined study including parameters such as choroidal thickness and ocular perfusion pressure will certainly yield better results. Thank you.
Thank you. How did you come to the sample size of 96?
Sir, this is according to our OPD patients. Sir.
But you could have calculated. I mean, it's a
Sir,
good sample size.
sir,
I
I have
mean, I'm
calculated.
not questioning that.
Oh, no.
It is just that it was a little unusual
No,
that
no,
you come to
no.
96,
No.
and I didn't see a sample size calculation
Oh.
to estimate that. But I'm sure if you use your, as you have compared a previous study, I'm sure
Yes.
if you do that,
Yes,
it will
sir.
just add strength to the study and the presentation that you're making. Although it's not right to make a sample size estimation after the surgery, after your study.
Yeah. What are your exclusion criteria? So it is a migraine is a basically it's a meaning is a disease of exclusion.
Yeah.
What are your assessment protocol to exclude others?
Sir, migraine is basically a diagnosis of exclusion.
Yes.
Yes, sir. So, pardon, sir, I didn't get you.
So how did you exclude other pathological conditions? How did you come to that this is the only cause or the effect on the OCT that you are observing?
Sir, and sir, when we come to our exclusion criteria, sir,
I think what Dr. Saxena is trying to ask you, how was the diagnosis of migraine made?
oh, sir, that was from medicine department, sir.
Not by you.
No, not my, yes, sir. So, patients with medicine department who were
Medicine
diagnosed as patient.
department on what basis? On what background? You
Sir,
are
sir,
evaluating.
I will clarify totally. Sir, patients came in our OPD. They were shuffling between medicine department and ophthalmology department. They went towards their refractive error. After correcting also refractive error, they complained of headache. So the medicine department guys diagnosed as migraine. So we took them as such patients.
This is actually basically in our practice the over diagnosis of migraine. There's a lots of other even simple hypertension, sinusitis, so many issues are there
Yes,
in
sir.
OPDs in reality.
I agree,
And
sir.
everyone tell is a migraine. Actually not. There may be some even as a ophthalmologist we are also a MBBS student. We can examine in our bidirect also ophthalmoscopy. Is there any DNS?
Yes.
Tenderness on the sinusitis, and the one is important is labile hypertension.
Never.
Those are initially missed by lots of the doctors. Yes.